or work with your clients. So let's get started here. Let's see on my schedule, the life of an academic. All right, y'all. So you probably noticed quite a bit of overlap within these three articles, within these three chapters, which I promise you isn't a bad thing. It basically means that the messages are quite consistent when working with this population. So I'm going to minimize all of you so I can see what I'm saying to all of you. And I'll be going in and out looking at YouTube videos as well. So I've got a little bit of multimedia going on here. I am very interested, as I've said to you before, of like letting me know how you like watching videos. I've gotten a little bit of mixed feedback around the use of media, and it's like I'm already staring at my computer screen. I don't really want to watch videos too. If there's something different that I can do to share this stuff with you, just let me know. Okay, so the first thing I want to do is highlight to you the importance of attending to your client when they come to you, and also recognizing the importance of some skills that you can teach right off the bat. So you know how like we talk about building safety and really highlighting the therapeutic alliance, all of that is incredibly important. At the same time, like if you're kind of putting yourself in the position of a client, if I'm coming to you because I'm having intrusive thoughts, if I'm having flashbacks, if I'm feeling completely out of control in my own body, in my own environment, if I'm sitting here as your therapist being very empathic and, you know, asking you about your experience, it may become quite frustrating of, you know, when clients come to you with a presenting issue, they want ways to not deal with, not meaning not deal with, but not continue to struggle with their presenting issue. So off the bat, I think it's incredibly important for you to give practical tools and techniques to your clients. So this is, I found a video of things to share, like, okay, so things to share with your client. You don't have to share this YouTube video. You can. YouTube's great for a lot of things. But you'll see from the person that is speaking what it is that they provide for their clients. So I might, again, lots of stuff going on. This isn't it. Yes, I think this is it. No, that's not the one. This is the one, I promise. Oh, come on. Why are you not moving? There we go.
Person has experienced trauma, almost nothing feels safe. And when someone doesn't feel safe, no amount of talk can convince them otherwise, because trauma is something that happens deep in the core of our brain and body. So how can we work with both the brain and the body to help patients feel safe, particularly when they're not in your office? In the next few minutes, Dr. Peter Levine is going to demonstrate 2 techniques that patients can use to self-soothe and self-regulate. And what's especially useful about these techniques is that you can give them to your patients to use whenever and wherever they are. Let's hear from Peter.
When a person's feeling traumatized, nothing feels safe. Almost nothing feels safe. And as therapists, what we want to do is to be able to convey, at least in the smallest amount, an island of safety. That there is a way that you can feel safe, that something has happened to you, you survived it. Now we're going to go back up and pick up some of those pieces that you left behind so you can be whole again. The other thing that's important in trauma therapy is that as soon as possible, that the therapists also provide tools, help the client learn tools that they can use to help them feel relatively safe. Because if the only place they feel safe is with you, the therapist, then when they leave and then they start feeling, horrible again, terrified, helpless, then sometimes, very frequently actually, they'll kind of shame themselves, what Fritz Perls called the top dog, because you're not able to, they're more dependent, they're completely dependent on the therapist. And so if we can give them even the smallest tools for self-soothing, for self-regulation, and I mentioned a number of them. I demonstrated a number of these with a person, with a client. This is, I don't know if you can see this. Let me maybe move back a little bit or something like that. Okay. I'm gonna get up on my haunches here. Here, you take your right hand and you put it here under your left arm on the side of the heart. Yeah, got it. And the other hand on the shoulder. And
Feel free to
just
try this
get
too.
a feeling, Ruth and everybody else who's watching, what this feels like, what the sensation is like, not just of your hands, but of what's going on inside of your body. Most people report a settling. What this does, I believe, is it helps us become aware of our container. See, and we'll probably get into this a little bit more. The body is the container of all of our sensations and all of our feelings. It's all in the body. And this is the container of the body, is the kind of the outside of our body, our shoulders, the sides of our thorax and so forth. And when the person can feel the container, then the emotions and the sensations do not feel as overwhelming because they're being contained. Another very simple thing people can do, usually I suggest they do this one first. The second one is just putting a hand on their forehead and the other hand on their upper chest. And just to wait, they can do this with their eyes open or closed, whatever they feel more comfortable with. A lot of people like to do it with their eyes closed, or others don't feel safe enough. To just feel what goes on between the hands. Sometimes they'll feel like an energy flow or a change in temperature or a feeling. And I just ask them just to keep their hands there. It could be just a few moments. It could be 5 or 10 minutes until they feel some kind of a shift. And then to take the upper hand here, keep the lower hand on the chest, and then put this hand on the belly. And again, just wait until there's some shift, till there's some flow. And sometimes people, if they're unable to sleep or they're afraid they're going to have nightmares, if they do simple things like that, they fall into sleep much better, and often the dreams are much more useful dreams. There are other techniques, the tapping, the energy psychology kinds of things. For some people, that works very well. Other people, you can use like tapping. Another thing I suggest is actually literally tapping the skin all over, so you get a sense of the boundary, because traumatized people, there's a hole in their boundary. So as you kind of help the body remember that it is the container, then they feel more able to deal with their sensations and their emotions. Also, squeezing the muscles, different parts of the body, also helps with boundary, sense of boundary.
When the nervous system has been hijacked by trauma, it's crucial to resource patients with these kinds of body-oriented techniques. And when we do that, we're giving patients the tools they need to feel safe, not just when they're with us in our office, but also so that they can restore their own sense of safety between sessions. Now I'd like to hear from you. As you've watched Peter demonstrate these techniques, how will you use them in your work with patients? And what other techniques have you found effective in helping patients feel safe? Please leave a comment below.
All right, so I wanted to show you some very practical things as you can understand some of the rationale behind that, because it is important that we create a safe space for our clients, of course. At the same time, to Dr. Levine's point, if we are the only safe space, if our office or the setting that we are in is the only safe space for our client, that can inadvertently create some sense of helplessness or hopelessness within the client, because then they think, I don't know what to do outside of here. I am questioning my self-efficacy. I'm very ashamed of especially if their kind of like go-to emotion around their trauma is shame, I feel shame in the fact that I don't know what to do away from my therapist. So we're walking this, or we're balancing this sense of safety, creating safety, and this understanding that there's potential dependence that is being created. And I'll talk more about the nuances. We touched on this a little bit last week about acknowledging attachment style and how they're giving that nod to attachment style, that there are certain clients who it is necessary and appropriate to be quite available and to really lean into some of their attachment style, while there's others that if we get close, if we really try to be super present or with them, that becomes overwhelming due to their attachment style. So I just wanted to give a nod and highlight the importance of this skill building off the bat as well. This is another place where you can very explicitly give the choice. It may be very important for you to, and I'm speaking as a therapist to the client, it may be very important for you to have practical skills. I also want to be aware of moving at your pace and really attending to what's important to you, because your client may say, no, I really want to get this stuff out there. I really want to start to understand what is going on with me, why this is happening, and these skills are of secondary importance. So I always share this stuff because we have kind of, it's not an assumption. It's like these maybe like generalized beliefs around what we believe is helpful, but we always have to remember the nuances and the idiosyncrasies of our clients. So to say it is generally important that clients have skills to use when they are feeling overwhelmed, when they are on the verge of a panic attack, whatever. At the same time, if you just leave that assumption and say, okay, I'm going to give you all these skills, your client may walk away feeling very dismissed or very unseen because they really wanted a space to start processing, or they're feeling very overwhelmed at the possibility of using these skills because maybe they're unprepared or something. So always recognize that our field is built on theories, right? And theories we're taking our best educated guess at what we think is going on with human beings. And so it is impossible for our theories to be applicable to everyone. So that's where us as individual therapists and being very attuned to and creating space for our clients is so important to say, here's something we have. Would you like this? Do you see utility in this? No? Okay, let's go in a different direction. So just wanting to make a nod to that. All right, let's keep rocking here. Okay, so I'm about to show you another video. But so one of the things that you might encounter in your time with a client is seeing acute stress or crisis right in front of your face. This can be incredibly overwhelming for you as a therapist. So we'll talk about things like vicarious trauma and stuff, but it can create some, helplessness, some panic within you. And I just really want to normalize that for you, that it is, because we talk a lot about, angry clients or, clients with this array of emotions. but we don't necessarily experience it. And just like what we've been learning in this course of, we can theorize all day about, if I were in that situation, this is what I would do. But we really don't know how we're going to respond to this. And the best thing that we can do is prepare for it, and really understand the stance that we need to take when we have somebody in front of us who is in a crisis, who is having an emergency. So you have the option. So there's many different grounding techniques. I'm going to show you one of the most kind of like popular grounding techniques, the 5, 4, 3, 2, 1. You very well may have heard of this. But as an individual is going through treatment, and prior to treatment, there are moments where they may be overcome with and overwhelmed by their memories, by their emotions. So again, something that may be helpful is to provide them with techniques of how to ground. So grounding really means bringing that person to the present and reminding them of their physical and environmental boundaries. So when somebody is in, the thick of a memory, as we've learned, that person, when they're in a flashback or they're having these intrusive thoughts or these intrusive memories, they can lose track of time and be in that experience. So they believe in this moment, I am in danger, when in reality, in the present moment, they're not. So grounding is to create this clear boundary between the past and their memories and the present and their current reality, their current experience. So just to be very transparent about this, having grounding techniques and having this in your back pocket is important. Also, each client may respond very differently. So let's say that you're, maybe processing some traumatic memory, or, you're moving through that, where the person is, kind of being taken back into that time. They may become flooded, they may become overwhelmed. So as it says in this first point here, it can be helpful in acute situations. However, by its very nature, it's disruptive to the process. So we're in this flow, we're talking, and I am escalated, I am in a panic, I am overwhelmed, I am flooded. So it can alter the narrative and the relational stream of psychotherapy. So it runs a risk of implying, so when you say, okay, let's go into our grounding experience, you may be sending the message that this is an emergency. This is, we have gone off the rails. And so whenever I talk to, my students about these possibilities of what might happen, I encourage you to do the same thing with your clients. So having this be, and we'll talk about this in later slides, of this being part of the introductory process. So we read in, I think the treatment of complex trauma reading about the importance of your introduction as a human, and then your introduction into your form of psychotherapy. So this very well can and potentially should be part of your informed consent. There may be times, I'm saying this as if it's in the informed consent, or if you're saying it to your client, there may be times when we are processing or discussing something that is very much connected to your trauma, or maybe not. Because as we know, sometimes there's no readily identifiable rhyme or reason to an intrusion, to a flashback. So to be very overt about this and normalize it right off the bat of, this is something that could happen. We have techniques, and this is what we could use. I want to be very overt about this, because I don't want you to be concerned about my use of it. Really what we're doing is attending to what's happening in the room. And there, you may feel out of control. You may feel shame about the necessity of this technique or this intervention that we're using in the room, and that is okay. And we absolutely can process that. So, so grounding should only be used when it's clearly indicated. And this is where you can talk with your client. Have you ever had an experience where you've been very overwhelmed? Maybe you've lost track of time and space. And if that is the case, was there anything that was helpful to you? If something didn't work, please let me know what that was so I don't reuse that. So I don't use that and potentially further, exacerbate the issue. So you want it to be adjusted to the minimal necessary level. So this adaptation of, we're not hitting the trauma with a sledgehammer if it's only a tack and we only tap it. So you want to reduce the client's internal escalation, and it should be framed in a way that doesn't stigmatize the client or over dramatize what's going on. So these are some steps for grounding. So you want to focus the client's attention onto you and therapy. So orient them to time and space. So this is, you want to bring them, kind of externalize them from their internal process. There's a lot of chaos that's going on internally. And if you were to say, how are you feeling right now? What's going on? Likely that's going to just exacerbate what's going on because they're potentially not able to articulate that. It's so much chaos that if they lean into it, it's going to escalate them even more. So you want to pull them out of their internal process and what's occurring with them internally and pull them externally. So if you also want to, at the same time, so you don't want to process what's going on in there, like, tell me everything that's going on, because you may say, just invite them to let you know, like, what's overwhelming them or how they're feeling, because it might just be oh my gosh, I'm so overwhelmed. So you don't want to take time to like unpack that. You just want to, okay, great. So here is, I just have a, so because you want to orient them to the, or you want to get them familiar with at least identifying what they are feeling, but you don't want to go in and stay there in that internal process. Because as we've learned this week, the understanding and identifying of those internal processes, that feeling is very important to feeling some sense of control and agency over that. If I can identify what's going on, if I can identify what happened to bring me here, then it gives me some control and some power in this. So briefly describe, invite them, you're not unpacking that. And then you want to orient them to their immediate external environment. You are with me, Sarah, Dr. Lappin, whatever, and you are in Los Angeles, California, in my office. You are safe. Let's be here. So then you want to focus on breathing or other methods of relaxation. This would be something that you would want to do a little bit of assessment around before, to say, so what have you found when you are feeling overwhelmed, when you may be feeling flooded, and they may need a definition of what flooding is. Because again, we use a lot of jargon in our field. So you really want to make sure that this is what we're saying and what the interventions and the language that we're using in the room are very accessible to our clients. Focus on breathing or other methods of relaxation, and then repeat step 2, which is orient them to the immediate environment, and then go to breathing. So it's an iterative process that may be staged in the de-escalation. So I want to show you just one option for doing, this is very specific of like, let's have a kind of a dialogue around this. What's going on? Let's breathe. You are here. Okay, now what's going on? Let's breathe. You are here. So this iterative process where the steps 2, 3, and 4 are continually used until that person is feeling less escalated. So here is the technique called, oh, now where is all my stuff? Here it is. Let's minimize this and go to grounding. Yeah, here it is. So this very well may be something that you have heard of, used. I will share with you a modification to how it's presented here, like another option. So you'll be in, also just letting you know, you'll be invited at the end of this. So the end of this video is about like a minute, minute and a half of you going through the method. So I really encourage you, once you learn what it is and see how they use it in this video, to take some time at the end to actually go through this. So just inviting you to try this out for yourself.
The 5, 4, 3, 2, 1 method is a grounding exercise that can help you stay in the moment and avoid negative thinking and worry. You can do this exercise anywhere, at home, at school, in the car, or even in the middle of a crowd. You can do it sitting, standing, or laying down. Counting down from 5, use your senses to list things around you. Make an effort to notice details about these things. This is how to do it. Start by breathing deeply in through your nose and out through your mouth. Then slowly look at your surroundings. Find 5 things that you can see around you. Maybe you see a colorful poster on the wall, the spider web on the bookshelf, the lamp on the nightstand with the red shade, the cat sleeping peacefully on the chair, the cactus on the dresser that has finally bloomed. Then list 4 things that you can touch. The warm mug in your hands, the soft comforter on the bed, the denim of your jeans, the scratchy carpet under your feet. Next, listen for 3 things you can hear. Maybe the ticking of a clock, the quiet hum of your computer, the sound of traffic from outside. Now try to find 2 things that you can smell. The tea in your mug, the clean scent of your clothes. Finally, list 1 emotion that you feel. This is a way to ground yourself so you can feel present in the moment and in control of your surroundings. Now you try. Use this method when you feel overwhelmed to bring yourself back to the present moment.
All right, so I'm gonna stop my share. Does anyone have familiarity with that approach or like see the utility in that? Has anyone ever used it with a client or perhaps even with themselves? Would you care to share a little bit about that?
I used it like last week with one of my clients who has really bad anxiety in social situations. And she said she just kind of like freezes. So I had a printout of that and then I handed it to her and we did it in the room. And then yeah, she said she did it and she really like it really helped her. So
Great. So the alternative, thank you for that, Jesse. The alternative to the last one of one emotion that you feel is one thing you taste. So it's engaging all five senses. So again, with what we just were talking about in terms of potentially being in this very overwhelmed space, maybe a numb space to say like, what's one emotion? It can feel too much. Like I don't want to go internal because grounding is meant, so it is meant to ground you and orient you to the current, your present, which does include how you're feeling, but sometimes it's just too threatening to go inside. So just so you know, an alternative to that is one thing you taste. And sometimes it's like, I don't know, my mouth just tastes bad. And it's like, okay, you're in the moment, you're in the present. That's the whole purpose of this. So yeah, any other thoughts or reactions to the 5, 4, 3, 2, 1 approach to grounding or questions maybe?
I don't have a question, but I really like this and I really like that we're, covering this week because even yesterday I had a client and he has like really extensive background of trauma, like layers upon layers of trauma.
Sure.
And he experiences a lot of panic attacks. And also he had said that he doesn't get very good sleep. So he only gets like 3 to 4 hours of sleep each night. And we did a body scan yesterday and I was also just thinking, I was like, man, I really don't know a whole lot of mindfulness techniques or anything, so I'm like, I really need to brush up on that, find some things for him to actually implement.
Yeah.
Because we were talking about how he reacts to like feeling those panic attacks coming on and what he does to stop them.
Great.
Or kind of like, suck them back in. But
yeah.
He had said that what he does is he thinks about all the things that he's worrying about and tries to find solutions to them, which I feel like is like the opposite of what he should be doing because that's the things he's worrying about.
Sure.
So I had, try to bring him back into his body and what he's just like feeling or sensing.
Yeah.
So I think this could be like a super beneficial technique to use.
Absolutely. And for your case in particular, Jada, if you're familiar with or can do like even some quick reading on because of ACT, acceptance and commitment therapy. So it's kind of, there's some, you don't have to use this. It was just a thought of like, maybe something that could be of utility with this client so we have CBT, which is really about changing cognitions, right? And then we have ACT or acceptance and commitment therapy. That's really about accepting where they're at. Like, so, it's normal to have worries. It's normal to want to find solutions to those worries that may not always be realistic. So acceptance and commitment therapy is really rooted in some acceptance of the lack of control that we have. And some clients hate it. That's why we have multiple approaches to their presenting issue. So I just introduced that to you because it might be something where there is liberation in saying, oh, like worries are a human experience and I can't always find a solution. Let me go into mindfulness. So acceptance and commitment therapy has a lot of mindfulness woven into it. Like it's, like many of my past students who are yogis really like it. So anyway, for what it's worth, that's potentially something that might be of utility to you. So thank you for sharing, Jada. Any other thoughts or questions on 5, 4, 3, 2, 1? All right. Let's keep going. I don't know where my stuff goes. Here it is. Technology. Okay. So here's some other like interventions, just so you are familiar with them and that you can introduce. So again, our default with maybe clients in general, but specifically with clients who have experienced trauma, particularly those who have experienced, a boundary violation of some sort, which is really nearly all trauma survivors or people who have experienced trauma, is that you give them choice. So you introduce potential interventions, potential things that may be helpful to them. So sometimes you can introduce, so this is where I really encourage you to have some understanding of like what medications are helpful for different presenting issues or different symptoms. As we know, we can't prescribe, but to have, so your default would be in this case, a referral. You may educate the client maybe a little bit on medications, but we really have to stay within our scope of practice. So it's this possibility of medication that may decrease the intensity of some of the interferences, some of these flashbacks, the intrusive thoughts. So they may be indicated. So this is where you can, refer to a psychiatrist, refer to clinical mental health in some way where they would have access to medication. As marriage and family therapists, and generally as mental health practitioners who don't prescribe medications, our stance is generally that medication should be complemented with talk therapy, some sort of psychotherapy. So then there's, as we were just kind of getting into a little bit ago, was relaxation and breath control. So this is this chronic affect dysregulation. I am feeling so out of control. Medication may be helpful. Also behavioral techniques like relaxation and breath control. So in strategically inducing relaxation, this can be, Jada, if it's okay, I'll kind of run with some of your examples since you shared it, of its application to your case and to your client as I'm talking about these different interventions and techniques. So this could be something maybe that your client recognizes before bed, that their worry is quite pervasive, because our systems are kind of shutting down naturally. Even with an experience of trauma, at night there is some relaxation. There's usually less kind of activity that's happening in our brain, so it also allows for, or potentially invites some amping up of that, of let me think about all the mistakes that I've made, or all of the worries that I have, because I don't have anything else kind of stimulating me or distracting me. I'm just laying here. So this could be a place where your client, for example, Jada, can strategically induce relaxation through breath control. So there's two types: progressive relaxation, which we covered 2 weeks ago, maybe last week, and then mindfulness-based breath training, which we will do today. So you're teaching the client how to breathe during stress, which can help restore normal respirations, because as we know, when we're stressed, our breaths become shorter. They are not as deep into our lungs. And so when we send this physiological sign, it also activates our brain to believe that we are in danger. So having the cohesion between the reality of the danger and the soothing mechanisms within our body that can help alert our mind that we're okay. So you're doing work in here going like, reassuring yourself, I am safe, I am okay, you know, whatever kind of maybe affirmations could complement this kind of stuff. And of course, adequate oxygenation to the brain, like when we're depriving our brain of oxygen and we're not taking these nice deep breaths, that we're damaging our brain. Our brain needs oxygen. So then other options for, so these are things to kind of try to consistently put into practice. Like they're preventative in a way of future progression. They're also interventive by nature of somebody who is struggling with something. So they're preventative of like potential, poor prognosis or poor trajectory. They are also intervening right now in times where I have been struggling, and gives the client, again, choice, options, feeling some sense of agency around, oh, there are things that I might be able to do to feel in control of my experience, because I'm consistently feeling out of control of not only my thoughts, my emotions, maybe my environment. I'm so overwhelmed. So mindfulness meditation. So this is very consistent with ACT, acceptance and commitment therapy, of saying, I'm noting these negative, repetitive, and habitual thoughts and feelings, and then potentially moving your attention toward other processes while accepting the fact that these things exist. So what can happen with us is when we have negative, repetitive, habitual anything, when it comes to us, we judge it and we think, shit, it's happening again. Oh my gosh, oh, I'm so frustrated with myself. Why can't I figure this out? So then our response almost, so we're responding to our reaction to the thought, right? So it's kind of almost this like secondary process that's happening of this thought comes in and you go, shit, here it is again. Oh, I'm such a failure. I'm so frustrating. So then you're not even necessarily responding to the actual thought. You are becoming amped because of your reaction to that. So with acceptance and commitment therapy, for example, it is a, oh, okay, so I am experiencing this feeling of shame. Okay, I'm noting it. It happens. I'm not going to judge it. I'm not going to place a value on it, because when we judge it, when we place value on it, we give it more weight, we give it more influence. So it's really this kind of like unlearning of the reaction to it and allowing it to do what I'll talk about in a couple of slides, kind of this like urge surfing. It's a little bit different because we tend to use urge surfing in like the addiction field, but it'll all make sense in just a couple of slides. And then yoga, which is engaging activities that produce positive states and preclude or lessen negative ones. So for anybody who's ever done yoga or anything maybe akin to yoga, it's about being present. And there are many like affirmations and this kind of like positive, gratitude oriented approach, mindset. And then yoga also helps create that mind-body connection while also doing something beneficial for your body, movement, oxygenating. So it is a form of exercise in a way as well. I say that just because it sometimes it can be not welcomed as framed in that way of its exercise, that that can become, I don't know, almost appropriated in some way. But anyway, I just say that because some clients may not appreciate it being framed in that way. So just having a conversation around the utility of this and some of the purposes of that, and staying in our lane about mental health. So again, it's about engaging the whole body, having a hopefully positive experience with people who are in it with you, so it can help build some sense of community, while also being led by a teacher, because even if you do it at home, so it doesn't have to be like at a gym or in a group fitness type approach, it can be at home. There's plenty of stuff on YouTube, but it's meant to produce positive states and lessen negative ones. So it's like you kind of breathe in some positivity and let go of negativity. Breathe in relaxation, let go of tension. Like it's a lot of bringing in good things and letting go of things that don't really serve you. So you also want to increase general affect regulation and the capacity to do so. So these types of techniques are increasing the capacity to tolerate and down regulate. So if you, again, having negative feelings, it may work really well for some clients to redirect, reframe, have the thought and say, okay, I'm recognizing it, I'm going to change it. That may work wonderful. I will also say in your back pocket, also recognizing that some clients benefit from, I have this negative feeling, this negative thought. Okay, I'm not going to work to change it, because it can be too much, or it's just maybe not congruent with their worldview and the way that they may think change or recovery looks like. So you want to so tolerating is more of that acceptance and commitment type approach. Down regulating may also be a consequence of the tolerating, but it also may be something where they're actively trying to change, like their emotional state, their thought process. And then the hope is that they're reducing the likelihood of getting overwhelmed later, because they're, putting in these processes, they're gaining confidence as they go, to help them in the future. So one thing that is generally thought in our field is that awareness can breed confidence and agency. So with affect regulation, it's the ability to label what's going on, or to have an accurate assessment of what's going on. So this may be a quite long process where there's a lot of education up front. There's a lot of modeling on your side. I think I've mentioned this in class before, but regardless of the presenting issue, I will provide my clients with like an emotions wheel or a list of emotions and encourage them to like go home and look up words that they're not familiar with, to increase the vocabulary. And then another step to doing that is I'll say, okay, once you kind of identify all of these emotions and feel like you have an understanding of what they are, which may mean that they come back and say, yeah, I looked up this thing and then I looked up the definition, I just like don't really get it. You should be equipped to be able to make that accessible. So let me give you an example of this. Let me tell you another emotion that it may be close to. Let me tell you about a time that I felt this or something. So you sometimes are the liaison between some of the materials or the homework that you give your clients and the taking in of that, the like internalizing it, the understanding of that. So once you have this list. So again, this is just a technique that I use. They have this list, they have these words, they define them, you help them understand them if they have difficulty, and then you assign them to identify a time when you felt that way. So it becomes more, so they have more like closeness to it. They have a better understanding of what it means to actually, and then helps them identify, what does this actually feel like? So you go kind of this intellectual, let's define it, to a, what does this actually feel like when I do experience this? So again, when somebody comes to you and they've had trauma, they've experienced some trauma, their internal state may feel incredibly chaotic, very intense, and like so much stuff going on that it's like, I almost imagine it sometimes of like these emotions like zipping through their consciousness, and they can't like quite grab one to be like, what is this? And then they like swirl together and it just feels so overwhelming. And then because they can't identify maybe, one single emotion out of this chaos, that nothing feels logical, nothing feels predictable. It's just chaos and overwhelm. So this could be something where if like when you identify and discriminate emotions, where you do some kind of meditation, some sort of relaxation, get them in this very down regulated position to say, okay, now that we're in a calmer space, a space where you're feeling like regulated, not threatened, safe, calm, now let's unpack some of this. And this is where you've done that, some of that preparation prior. You've given them some vocabulary. You've had them work on understanding some of this. And this could be where all of that is done in session, and it, you know, where we're like, all right, let's talk about emotions. You know, tell me some emotions that you're familiar with, and then let's expand some of that. Okay, let's relax and let's go into a moment, or, you know, maybe something that's much less threatening, and let's unpack some of what you were feeling. So you can assist the client by regularly facilitating exploration and discussion. How are you feeling today? So it's like this regular check-in, it becomes part of what you do. So emotions aren't these like scary things that I have no agency over. They're things that I'm becoming more familiar with and feel like I have some control and some power in this place. So I generally take the stance of not like feeding the client with emotional words, because it's inherently biased, right? So it's like, you know, they bring a situation to you and you think to yourself, man, I would feel blank in this situation. That is one perspective. That is your perspective. That is an inherently biased perspective because it's informed by your lived experience, and just all of your stuff. So as it says here, in all but the most obvious instances. So this is, you know, where maybe they've alluded to the emotion prior, or it's like a pretty universally evoking situation. Let the client kind of work through it. So this reminds me of, you know, the saying of like, teach a man to fish, he'll eat for a lifetime. Like, give a man a fish, he'll eat for a day. I think it goes the other way around. I fundamentally kind of disagree with that, because I think you can give a man a fish while teaching him how to fish. Like, because it's might be a lot easier learning to fish when you're not hungry. So I say this because you're free to have whatever approach makes sense to you, or maybe at first what you're doing is modeling for them. You know, I can imagine that you may feel this, or in this instance, I would feel this, and here's why. So you're giving vocabulary, you're kind of humanizing and making these emotions more accessible. And then you're like tapering off of that, of saying, let's explore this. So I really want to get you out of the habit of continuing to hand words or observations to your client. Oh, it looks like you are experiencing this. Instead of that, so tell me what's going on with you right now. How are you doing? What are you experiencing in your body? So that they gain confidence. So I think sometimes we really think we're doing them a favor by handing them some of this information, but what you may be inadvertently doing is fostering dependency and kind of sending a message to them that you don't really trust their own assessment. And because you have power, inherent power in this relationship, you have inherent authority in this relationship, that they can internalize that. And they may be hesitant to note anything because they're just assuming you'll do it better. So you're constantly encouraging them, constantly cheerleading them of like, you got this, we'll take the time that we need. There are no right or wrong answers. It really is about exploring, and letting them know, you know, it didn't take me one day to do this. Like, I just think of myself, you know, 36-year-old Sarah, like, who has made leaps and bounds in my ability to do this since I was 20, since I was 30. So, you know, potentially being very transparent about your own process of it. This didn't come to me overnight. I've worked on this for a long time, and I've struggled, and I've, you know, flubbed or whatever, but just being transparent in your own humanity as well. Okay, any questions, comments, anything over what I've covered so far? Okay, let's go ahead and take our first break. I will see all of you back here at 11:10. All right, y'all, let's go ahead and come back and we'll keep rolling through our presentation. All right, so again, recognizing that you have choice as a clinician in the approaches that you use, the techniques that you choose. Of course, you want to be educated about, like, what do we know does work? What do we know that is harmful? So I know I've been talking a lot between cognitive behavioral therapy and acceptance and commitment therapy. They're not necessarily juxtaposed to one another. They can be integrated. But again, so this is very focused, you know, as you read about the ABC model, that's very CBT true. It's like one of the core components of CBT. So I'll be talking about these in terms of, oh man, I thought I got rid of all of these. Anyway, sorry. So I'll be, because the books leaned this way and introduced them, I'll be talking about this from a cognitive behavioral therapy lens and integrating other things that were discussed in the readings. So identifying the thoughts, and then you have the option to show your client and to give them the tool of countering these thoughts. So we'll learn more specifically about antecedents. I think that y'all take like a CBT course, but even if you're not really familiar with ABC chain or anything like that, you'll be more familiar today. So one technique that you can provide and teach your clients is identifying their thoughts that may be an antecedent or preceding their intrusive emotions, their overwhelming chaotic emotions. So essentially within the CBT model, it's, you know, thoughts influence emotions, influence behaviors, kind of this loop. Behaviors influence thoughts, influence emotions, you know, so there's this kind of domino effect. If you change the thoughts, you may be able to change the emotions, which can change the behaviors, all of that kind of stuff. So what you're doing is identifying the thoughts that may precede these emotions that are overwhelming. And when the client is more aware of these thoughts that precede the overwhelming emotionality, they can feel some sense of agency. They can learn to lessen the impact of these thoughts. So one option here is to explicitly disagree. So whatever that script is, whatever is the thought, that narrative that they're saying, is so nobody's out to get me. So if their thought is, you know, I am under surveillance, I am constantly in danger, I am being watched, or I don't know if that's supposed to say I can't handle this. I'll have to change, I'll have to update the PowerPoint. So, or I can't handle this. You're merely labeling these cognitions as old tapes. So if for any of you who are, you know, familiar with schema therapy, it's this outdated schema, it's this outdated thought, this outdated belief, you know, that it's, you know, they're kind of living in a time that is no longer applicable. They are acting in a way and thinking in a way that is no longer applicable, though it was very helpful in their survival during their trauma experience, whether it was acute or chronic. So saying, you know, you're not in that space anymore. What are the cognitions that you are having? What could be like an antidote to it? So then trigger awareness. So this is understanding and identifying when, like what happens in the environment. So it's making this connection to these seemingly, you know, random emotionality, this unpredictable emotionality. So it's taking the mystery out of their process. So that's a lot of what CBT does. That's a lot of what we do as therapists, regardless of your theoretical orientation of demystifying what is going on, of helping produce and encourage insight. So when you are working with clients who have experienced trauma and who are, experiencing the residual effects of trauma, of helping them identify and address the triggers that are in their environment, the triggers that may be internal as well. So your environment's also your person, that activate these intrusive negative feelings. So when you identify the trigger, you can facilitate a greater sense of control and better interpersonal functioning. So, another piece of this, what we do is creating this system of support, encouraging interpersonal, safe, valuable, encouraging, all of the, positive adjectives that we can put on a relationship, positive relationships for them. So it allows the client to alter the situation so they have agency. If I know that I am triggered by a place, and I was unaware that every time I walk down this street or past this thing, that I am taken over. Now that I've identified that, I can find a different route, or I can work on changing my perception around that. So it's so again, this like triggers in the environment can be in the person. So identifying or altering the situations in which these triggers may occur and problem solve emerging negative states before they produce behavioral problems. And then we'll talk about what some of these behavioral problems might be. So delaying tension reduction behavior and urge surfing. So again, urge surfing is used a lot in addiction, of the addiction field, of having an urge to use. And really what it means is recognizing that waves come to is it a crest and then a trough? So if anybody knows what the actual terms are, if I just said them, a high and a low, please feel free to jump in here. But recognizing that there's a current that informs the peak of the urge, the peak of the feeling of wanting to do something to reduce a negative affect. So generally anything that we do to soothe is generally out of a space of a negative affect, a negative emotional experience. So they come to a peak, they may feel insurmountable, overwhelming, but waves always come back down into the low piece. So we're accepting that, I'm at a high, I really want to do this, but that won't last forever. So delaying is trying not to, and urge surfing are both trying not to suppress the triggered thoughts, but rather changes their relationship to them. So instead of going, at the peak, I must get rid of this, this will last forever, I am so overwhelmed, this is I can't deal with this, this won't last forever, I can work through this, I have to wait it out, I have other tools, and then it won't stay here forever. So with this, so I think one of the examples was a client who engaged in self-injurious behavior, where it's, delaying that as long as possible, because we may not fully remove the behavior right away. I mean, of course, the goal is if there's something that's self-harmful, that is maladaptive, that's not serving the person, that you want to replace it with something that's more adaptive, and or completely eliminate that behavior. So if a client is engaging in self-injurious behavior, it may be, okay, I have this feeling, this emotion, and within 1 minute, I have grabbed something to hurt myself. Okay, let's see if we can wait another 30 seconds. Can we wait another minute? So it's not saying don't do this is bad. So again, these value judgments about the wrongness or immorality of a given behavior, don't do that. It's not helpful. And I've seen it. I have seen this happen not only from clinicians, I've seen this happen from people in that person's life. So sticking with some of the self-injurious behaviors, one of the consequences of that is scarring. And it's I can't remember what setting I was in. So there were so many things wrong with this interaction. I'm good. It was not a supervisee, or I absolutely would have intervened because this was so bad. But so it was a young woman. Oh, it was in my master's. It was in my master's internship placement, which was in a partial program for adolescents ages 11 to 17 who are either in a partial program or inpatient after, some sort of self-injurious behavior, maybe a violent outburst, psychotic episode or something like that. So they're coming to us in crisis. And then our job is to stabilize and then move them out to outpatient ongoing therapy. So this one patient, because we were in a hospital setting, had been engaging in some self-injurious behavior where she was cutting like the inside of her thigh and then along her arm. So like perpendicular to the veins in the arm. And she had also been cutting like on her shoulders and stuff like that. And I know, and now it's all coming back to me now. So we, in inpatient settings, for those of you who aren't familiar, or maybe for those of you who have something different at your placement, is we had like a care team. So we would have like nurses assistants, we had a resident on staff in psychiatry, we had a supervising psychiatrist, there were us as the clinicians. I was studying at the time to get my master's in counseling psychology. We had, team meetings with the family, but we had just people in a lot of different roles. So it was one of the nurses assistants who basically like, they were the ones that stayed in the room with the kids, adolescents, like in between maybe psychoeducation sessions or something. So they'd be with them for like maybe 15 minutes at a time. But the purpose of their role was to like feed them when it was mealtime and then never leave them unsupervised. So one of the, and like the adolescents were around them enough that they probably interacted with them like the most consistently out of any of us, because there were several clinicians on staff where, we might only see the adolescents like an hour a day or something, but they were consistently with the nurses assistants. So they would have conversations with them, like their role was inherently more like informal and stuff like that. So, and you'll be able to hear some of the errors in what happened. Sorry, I just want to like see all of you as I tell this story. So this adolescent had multiple like fresh cuts on her arm, scarring, and the nurse's assistant said to her, like, aren't you worried about having scars at your wedding? Like just so many assumptions and so much shame around that of like, this is a poor decision that you are going to look back on and feel guilt about, feel embarrassed about. And surprise, surprise, the adolescent didn't respond very well to that. I actually think that she may have gone into like a crisis from that, of just, looking at the lack of trauma-informed response to what was given to them, to the adolescent. So I just use that as an example of like, never what to do. It's always like, I see what's going on. Like, let's talk through this. I am not here to judge or value this at all. So one of the things that I really do encourage you all to be incredibly aware of is your nonverbals in that. Like, you may not say it, but the way that you sit, just like the way that your body posture is, the tone, the cadence, like there's so many things that you have to be aware of that inform the message that you're not necessarily saying. Does that make sense to everybody? It's like this incongruence between what's the words that are coming out of your mouth and the way that you are saying it. So you may fundamentally disagree and be like very worried and concerned about your client. And you may be thinking about things like, in 15 years, they may be so sad about the decisions that they've made or the way that they've coped, which I think it's human to do that. but there's not really space in the room for that. And quite frankly, you are taking your own value judgment, your own assumption of what might happen in the future and placing it on the client, which is inappropriate. So yeah, a little bit of story time with me. Any thoughts, questions about that?
I was thinking too, when you had said that they're also bringing up something that person changed. Oh, that person can't go back and not cut anymore.
Right,
Like the scars are there.
exactly.
So, right, yeah.
Yeah, so it was so insensitive of, yeah, I thought of the same thing when I heard it. And again, I didn't know what to do in the moment. It's just like I was in an intern position, which isn't necessarily an excuse, but I had some history with this placement where I didn't feel safe or comfortable to assert myself in that moment. So I went to some of my fellow clinicians and said, holy shit, we have to address this. This is not appropriate. But yeah, so absolutely that of like, okay, cool. Now that you've pointed out this thing that's not going anywhere, what am I supposed to do with that? And it's like wanted to be to the nurses, like the nurse's assistant, like, what did you get out of doing that? Like, do you feel better now that you shared with this adolescent who's in a inherently fragile state being inpatient here? Like, you feel good about yourself? So anyway, I had lots of reactions to that.
Well, I just want to add
Yeah.
too, it's not a direct response to what you said, the story that you told, but you said, it's human to think those things, right? But there's not really space in the room to bring it up. And it just made me think, like, I'm exhausted at the end of my day of therapy. And it's like, I haven't really moved. I've just been sitting in a chair talking with people, which doesn't sound like that it's all that exhausting, but I think it's that separation of like being human, and then not to say that we're superhuman as therapists, but in a way we kind of are, not to put ourselves on a pedestal, but like we have to separate our own individualities with our therapeutic identities. And I think I kind of relate it to, in a metaphorical way, kind of being like an actor where we are playing a part in some way and we have, boundaries that we have to hold. And I'm just thinking of my own, like, why am I so tired after seeing 6 clients? Because I'm just sitting here talking. Like, why is that so exhausting? And I think it's that reason there of like separating our initial reactions. Like our brain is constantly filtering what to say and what not to say.
Absolutely. And I thank you so much for that, Miles. One, love your shirt. Second, is that you're right. What we do is inherently performative. Like, so yes, are we congruent and true to ourselves? Hopefully yes, but is there a filtering aspect of this? Is there a much heightened awareness and insight into how we're sitting, what we're saying, what we're doing, this hyper awareness of all of the space that we take up in the room? Absolutely. Is that exhausting? 100%. So yes, thank you for pointing that out, that what we do is it's performative in nature. Any other thoughts or questions? All right, let's keep rocking. Where are we? All right. So recognizing the staged process of what we're doing. So as you know, like the second phase, generally, like the third phase of 7, the second phase of 2, but there is a built-in piece to really all of the approaches to trauma, of processing the trauma, of giving agency and presence, and looking at it from the client's current state, and having that integration of, yes, this thing happened to me. I have this history. It doesn't define me. I have some separation from it, but it's also part of me and part of my story. So I highlighted this sentence and what is from the reading to encourage in you patience of it's later in the PowerPoint, but recognizing that, you know, this the stages of safety and stabilization and then processing, it's iterative. So meaning that you go back to one to then go to the next, and then you go back to one to go back to the next. So it's as they are experiencing these levels of distress, that they are inherently, as you're creating space for safety and processing and these self-soothing techniques, that they are like slowly going to be able to integrate this into the process. And then the hope is that they're able to either reframe or accept or both these upsetting thoughts. And then you're creating this community to call upon relational support. So you are inherently a relational support because you're a human interacting with your client. But this is the hope of the repetitive experiences of experiencing overwhelming and destabilizing levels of distress, that it becomes like more and more tolerable, or because they're getting practice, and or because their perceptions around the distress are changing. So we essentially have two options that may complement each other, of changing the behaviors as well as changing the perception of the stress or of the trauma. So we're kind of in tandem doing both of those while giving them tools behaviorally, also giving them tools cognitively. All right, moving on to, I believe, the Herman text. So talking more extensively and repeating some of the stuff around safety, stabilization, and engagement. So again, highlighting what the title says, measured in skills, not time. So please don't pressure yourself in terms of, okay, by session 3, we must have this. The kind of only caveat to that is, you know, if you're working with a client that is paying through insurance, or insurance is reimbursing you, insurance may limit what you're able to do in terms of time. So they'll say, yep, we'll cover 10 sessions for this client, and this client can't pay for anything more. So then you have some decisions to make. It may be that you offer, you know, subsequent sessions at a reduced fee, you know, that you work within the frame of the 10 sessions. But anyway, so if you don't have externally imposed timelines, please stick with skill building and take that pressure, liberate yourself, take that pressure off and liberate yourself from this like arbitrary timeline that it's generally arbitrary of what progress looks like and how quickly it should be happening. So just a note here of, so recognizing that your clients may be engaging in some sort of self-harm behavior or some compulsory behavior, that again, it has been a tried and true, consistent, dependable coping skill, coping mechanism for these overwhelming, distressing emotional states. So asking a client to just quit doing what you're doing prior to us moving into anything may be well-intentioned. It may also be unrealistic and, quite frankly, harmful. So some degree of trauma processing might need to occur for the client to feel like they can let go of some of their coping mechanisms that no longer really serve them. You know, in hindsight, they never really served them in the best way. But again, when you are in survival mode, it is any means necessary to keep going. And if that means engaging in self-harm, using substances, I'm just trying to get through the day. And what is happening within me is so overwhelming. It's so terrifying. It's so horrifying that I need some place to escape. I need some other place to put my attention. These things are keeping me going. So also a note is that some clients may never move out of phase one. Like your job may be only to provide, and I say only, not meaning like that's incomplete, but you know, this is an approach that is 3 stages. So if you don't complete all 3 stages, it's in a way incomplete. Anyway, I'm going to take that back. I'm going to edit myself out and say, if you complete phase 1 and you're doing phase 1, and that's the only thing that you do, that may very well be appropriate. So some clients really don't ever have the skills and ability to move into trauma processing. This could be due to a long history of abuse and neglect where they really just don't have the internal resources. They don't have the ability. And it's not a failure. It's that you're meeting them where they are and giving them the tools that they are able to use. It may be that they never are able to process their trauma. It may be that it's years and years down the road that they're in a space to do it. So some clients don't move beyond phase 1, and that may be due to their history, their, capacity. It also might be due to that's really all they needed. They needed safety, they needed stability, and then they don't need a professional to move forward and do the rest. So I just put that out there of saying, like, we do what we can. So please don't feel like you didn't do all you could for the client, or that you're feeling, like a failure, incomplete by the clients not moving through the entire phased treatment. So phase 1 really is about resourcing the client. So this means that resourcing is like giving resources to, maybe not, they're not handouts, but it's like resourcing, meaning like increased internal capabilities and that kind of stuff. So I just wanted to outline to you what some of this resourcing can look like. So you really want to focus on strengths and resilience. You want that to be a part of the narrative and interwoven throughout the process of, I see these things in you. And it's not to like dismiss their struggles or the things that they're struggling with, to say, look on the bright side. That's not the message we're wanting to send. It is, you are inherently capable. I believe in you. We're going to do this. So that's kind of the underlying message of, you've made it through 100% of the days so far. You're here, you are seeking help. And that in itself is a strength. So you also want to provide them continued assessment of their attachment style. So as I said last week, and I alluded to earlier in this, in class today, is that, some clients need more connection. They need more from you. And that's informed by their attachment style. So again, feel free to do a formal assessment to see, I have a disengaged attachment style, a disorganized attachment style, I have an ambivalent attachment style. So then I'm going to kind of move in coordination with that. I'm going, my approach, my position is going to be informed by what I learn about the client. So because you may need to be, metaphorically closer to a client who has a certain attachment style versus, this more distant attachment style, where if I were to be metaphorically close to the client, they would be completely overwhelmed and really put off by that. So you also always, so this is, I really want to highlight the continued assessment. I think sometimes we have this misunderstanding of assessment that it's at the beginning and then you don't do it again. Like there's this formal process where I give you a battery of these things at the beginning, and then the rest is action. The rest is the therapeutic work. Assessment is inherent in all of that. So you may not be giving them formal, like written or, electronic assessments. You might be just like informally asking them questions, but you really always want to assess for risk and danger. Because I think an overlooked piece of what we do with individuals who experience trauma is we don't consistently and continually assess their living situation, their environment. Because if you are assuming that, you know, they've come to you because they're out of the situation, it's not ongoing, you are giving them, I would argue, like irrelevant and ill-informed care, because you're not truly speaking to their reality. You're not truly speaking to their context. So, you know, what is going on? What's your living environment like? What's the environment like? Who are the people that you are surrounded by? What are your relationships with these individuals? So this continued assessment of risk and danger, ongoing education on what is victimization and trauma. So as we've talked about before, the client may not conceptualize what they went through as traumatizing or as victimizing. It may be because they don't know any different. At the same time, what I really want to encourage and really punctuate for all of you is please don't get into a struggle over semantics. Like if they call something, you know, a unfortunate experience, I wouldn't encourage you right away to say, it wasn't an unfortunate, it was trauma. I get that there is some like validation in that there, at the same time, the client may feel kind of attacked at this like policing of the language that they use. So I want you to be aware of the balance of validating and saying like, this was abnormal and it was not your fault. And what you experienced was horrifying. As opposed to like, no, we're going to use the same language and you better believe that what you experienced was this. And I know none of you would do that, but I just want to be very overt about the messaging again, in that those nonverbal, that nonverbal communication that we give to the client. So you'll also be engaging the client in treatment and the development of the therapeutic alliance. So that's constant. You're privileging the therapeutic alliance. So for those of you that are familiar or unfamiliar with common factors, is there's essentially like 3 elements. So common factors, for those of you who aren't familiar, means all like factors that are common throughout all therapeutic approaches. You know, so narrative, CBT, ACT, family systems, EFT, you know, whatever approach that you can think of, they have these themes and these factors that are common amongst all of them. And they are agreement on the goals. So client therapist agreement on the goals of therapy, client therapist agreement on the tasks that will achieve the goals in therapy, and the therapeutic alliance, so that relationship. And so there's lots of ways to work on that, but really the like main kind of stance that we take is allowing the client to lead in terms of pacing, content, you know, having this empathic stance, this calm demeanor, this modeling of affect regulation, this modeling of acceptance of and of ambiguity, of uncertainty. So it's just really meaning like occupying the same space as a client, that's low pressure, to allow for them to just feel like, hey, I can trust this person, and they're not going to abandon me. But I'll get into some of the nitty gritty of that later. And then last, skills training for emotional regulation, life enhancement, and stabilization. Like these are the components of resourcing the client in this initial phase. So with ensuring safety, so you, again, this ongoing assessment of, are you in danger? What is your living situation like? Tell me about your current context. So you can really only disengage from the survival brain, which is, you know, what influences behavioral choices. So things like self-harm, things like substance use, or any other, you know, survival coping mechanism. If the client is currently in danger, they can't disengage from that survival brain, because even if in your space they're safe, you haven't fully accounted for their context, for their environment. So you really want to stay on track with that and aware of that and ask about that, because only once they decrease danger in their external environment are they able to engage the learning brain, which allows for them to be able to process, which allows for them to be able to be present, all of these elements that are necessary for progress in their trauma healing. So again, treatment should be geared toward the development of safety in the client's life. Again, something that is both a short-term and long-term goal and ongoing and may take time to achieve. So, for example, if you have a person that is in your office, in your space, who has experienced intimate partner violence and is currently living with the perpetrator, there are realities that you have to attend to. So if they are inherently still in danger, it may take a while for them to relocate. They may never want to relocate, and you have to stay in step with that reality. So even though did someone say something? Oh, that was weird. Okay, even though we assess danger and monitor it, it's not realistic for us to assume the responsibility of eradicating danger in the client's life. So I say that for those of you who may, kind of take work home, and that's developmental at this point too. So for those of you that are like, should I take some stuff home? That's okay. That comes with more time and more experience, and quite frankly, more experience in seeing the resilience of clients. Again, I don't ever want to dismiss like the sincere struggle and the sincere like difficulties that humans experience. At the same time, if you feel that like you're the only one that can provide something, you're making yourself too big in their life. So, if you find yourself, you're calling shelters, you're doing all of these things, you want to bring your client home with you to, give them respite or something, this is where you really need to talk to a supervisor. You really need to consult with your colleagues, because if you're assuming that responsibility, you're taking on more emotionally than you can probably handle, meaning that you're creating some stress. You are kind of leaning into some of the hopelessness, and that's really not of benefit to your client. Also, in kind of tandem with that, the next point of, well, let me provide you something super quick that you can implement. Like, oh, I just came up with this after listening to you for 5 minutes and I have a solution for you. I do think that those are well-intentioned. At the same time, I really, really want you to understand the underlying and probably very unintended message that you're sending your clients is, I don't trust your judgment. I have better judgment than you. Let me come up with a solution for you that you've struggled with this issue for years. I've been with you for one session, and let me give you something that will change your life. I very much believe that the intention is good. I also very much believe that the messaging and the way that is received is not how you intend it. So you are essentially saying, I don't trust your judgment, and I don't trust your ability to determine when and how to best deal with your danger. And so when I very much liken it to, when parents or adults do things for kids, where if, you have a kid that's kind of like fumbling through using scissors, if you take the scissors from them and do it for them, you're saying, I can do it better than you. I don't trust you to do it in the way that I think it should be done. There's a right way to do this. So, let the client hold the scissors and allow and trust that the client is more aware of their context than you are. They are more in tuned with their reality of some of the, kind of like consequences of their behaviors than you are. You are inherently separated from that because you're not living their life. So when you provide quick fixes, again, intention's great, I'm sure of it, but you also send the message and you undermine the client's self-efficacy as well as a therapeutic alliance. Because again, you're sending the message, I don't trust your judgment on this, and I don't trust that you are right about when and how to implement changes. So what our job is, our lane is to, so instead of saying like, let me fix all of this, I'll put a down payment on, I'll pay your first month's rent, which people in professional settings have done. Again, it's not wholly unethical or anything like that. I think that what will happen is burnout, because you're just taking on more than really what's expected of you in a professional role. So our job is to influence the subjective appraisal and perspectives that underlie the client's behavioral responses. So that's our lane. We're working with what we have in the room. Are we also case managers? Like, do we do casework? Do we connect them to resources that can be beneficial in their lives? Absolutely. Do we take money out of our own pocket to provide for our clients? I don't think that's sustainable. Because you're really, again, that's the giving the person the fish, but not teaching them how to sustain on their own, how to instill in them skills to maintain the progress. So I'll just say my piece on that. That's my piece on that. So there's safety and stabilization. So in terms of stabilization, the concept or the technique of focusing. So the first step in stabilizing symptoms is gaining or regaining the presence of mind in order to be present, observe life problems and symptoms and be able to discuss them. So have the presence of mind, have the ability to stay present while discussing them, as opposed to getting flooded or habitually repeating repeating symptoms without feeling any sort of control or relief, or talking about them, getting flooded while you talk about them, or talking about them and it not really being beneficial. So the focusing is on the present. And so so after safety, you're stabilizing, or not necessarily. I think they can all be kind of this whirlwind thing of, not whirlwind, that sounds chaotic. I don't want to say that, but this complementary nature of safety and stabilization. So focusing is on the present and on skills that allow the client to stay present while talking about what has happened without getting flooded, and also feeling some relief by talking about it because they have some inherent skills in doing so. Okay, so we've talked about this. I'm just going to talk about it in a different way. So the behavioral analytic interventions that enhance mindfulness awareness. So I've alluded to this, the ABC chain. So A stands for antecedent. So what happens before? B is the behavior. So what happens before the behavior? And then C, consequences. What happens before the behavior? And then what are the consequences of engaging in that behavior? So again, taking the mystery out of this chain, because essentially what it is it's so automatic. We are unaware of the steps and the choices that we have in this process. So by breaking it down, saying what was the trigger? What happened? What were the thoughts? When you experienced this trigger, tell me what was going on with you. All right, what was the behavior that you engaged in to, kind of counteract or to cope with these thoughts? And then tell me how it went for you. So these symptoms can become more manageable if they're consciously recognized. So instead of turning away from them and avoiding them, which, it can be inherent in things like self-harm or substance use or isolation, these things that just really in the long run don't serve the client very well. But if they're avoiding, if they're dissociating, or again, if they're otherwise not noticed, I don't recognize it because it happens so fast and it's so ingrained, it's so automatic. I couldn't even begin to break it down. So you may need to do quite a bit of work at the forefront of this to give examples or something like that, or really work with the client while not saying well, I think this is what you were thinking of, giving them time and space to recognize that maybe they've never done this before. So they may need an entire session just to figure out any sort of triggers or antecedents to their behaviors. But when you take the mystery out of it, you give the client some agency. And then with that, I'm going to go ahead and pause because I want to, well, I'll preface the next part of this is, so how many of you are familiar with the trans theoretical model or the stages of change? Okay, so I'll be a review for, okay, hands. So a review for about half of you. Okay, great. So this wasn't in your reading, but as I was reading, I thought that it might be of utility to understand the stages of change and also give you some resources of potentially how to assess this. So one thing that I will say about the stages of change or the trans theoretical model is that when you establish goals or when you talk about like desired outcomes for a client, that just because they're in a stage of change in one goal doesn't mean they're in the same stage of change in the next. So you can have clients who, for example, outline 3 goals, and they may be in the contemplation stage, and this will all make sense when we go through, when they may be in the contemplation stage of one goal, they may be in the action phase of another goal, and they may be in the preparation phase of another. I say that sometimes clients are in like a pre-contemplation stage with a noted goal, but that's less common because pre-contemplation inherently means like I'm not really thinking about it yet. So that might be something that, it's pre-contemplation at the beginning of therapy, and then 6 months in, because you should be reviewing your treatment plan, then it pops up as a goal because they're now they're in the contemplation or maybe preparation phase of that. So I just really wanted to make that explicit of, if you were to assess one goal and say, oh, they're in the preparation stage, great. So they're probably in the preparation stage of the rest of these goals. Please don't assume that. They very well may be in different stages for all of their subsequent goals. So just on that note, before we watch another video, we'll go ahead and take a break. And I will see all of you back here at 12:06. All right, everyone, let's come back together for our last 50 minutes. So I wanted to show you a video of an explanation of the trans theoretical model. It's focused on like stopping smoking, but it's applicable to really any goal or any goal that a client may present to you. So an ad may pop up somewhere here.
If I told you there were strategies for holding on to habits until they became a part of your life? What if I told you that psychologists have actually found a set of steps that increases the likelihood of actually making a change in your life? Well, they have. And in this video, I'm going to go through each stage of something called the trans theoretical model. This model serves as a how-to guide for adopting a new habit or changing your life based on psychological research. People who successfully move through the first 5 steps of this model are much more likely to actually stick to their goals and adopt positive habits. This information is useful whether you want to quit smoking, whether you want your partner to go to the gym more often, or any other habit that you want in your life. Understand these steps of change, and you can help transition yourself or others into a more positive, happy, and healthy person moving forward. So, what are the stages of change? Now, this model was developed in the 1970s by James Prochaska and Carla Di Clemente. Prochaska and Di Clemente had been studying people who tried to quit smoking. They found that simply taking action didn't actually set people up for long-term success. They had to want to quit smoking before they could take appropriate action and actually stick to their goals. Permanently changing a behavior or picking up a habit does not happen overnight. Some of these steps will last for months at a time before a person is ready to move forward. If you want to see a loved one quit a bad habit or start a new one, it's important to be patient with them. And even if your loved one is in denial, they might be in the first stage of the trans theoretical model. And this means there's an opportunity for them to move forward. So step 1 is called pre-contemplation. The first step of the model is a pre-contemplation stage. A person in the pre-contemplation stage may be months away from actually taking action. They might not believe that taking action will actually be worth their time. They try to weigh the pros and cons of starting a new habit. They will downplay the pros. So think about some habits that you know are good for you. Maybe you think that a vegan diet would help you reduce your carbon footprint, but you don't think that the high prices of produce or saying goodbye to dairy is worth the switch. At this point, you would be in the pre-contemplation stage. More research is needed before you can fully get on board with the idea that veganism is a worthy lifestyle choice. It's time to ask yourself some questions about your health, your diet, and your carbon footprint. Now, in order to move out of the pre-contemplation stage, the person needs to look within. A shift in perspective is necessary before the person can see that their actions are hurting themselves in the long run. They may have a hunch that a change needs to be made, but the brevity of their current actions just isn't apparent to them. But after it does, they move on to step 2, which is contemplation. Once a person really starts to think about the consequences of their actions or inactions, they enter the contemplation stage. Now, many people stay in this stage for months or sometimes even years. They understand that their behavior is hurting themselves or others, and they can see themselves making a change within the next 6 months of their lives. But something is still holding them back. For many people, they still have a skewed view of change that prevents them from moving further. They see change as losing or giving up a habit that has been part of their whole life or whole identity. This overshadows the benefits of gaining a new habit. For example, smokers tend to marinate in this phrase for a long time. They understand that smoking is bad for their lungs, but smoking also provides a way to socialize or de-stress. And smokers have a really hard time accepting the idea that they will have to have a coffee without a cigarette, or they can't take a smoke break when things get hectic at work. So how do you get out of this contemplation stage? Identify the things that are holding you back. Does the loss of a cigarette with your coffee really outweigh gaining the ability to take a job without losing your breath? Or does the annoyance of moving your schedule around outweigh the benefits you'll gain from going to the gym in the morning? Continue to look at the pros and cons of changing your behavior. Sometimes strategic thinking helps with this. When you get to a point where you feel confident to move forward, validate your readiness and confirm that it's time to change. Next, we can move on to step 3, and that is preparation. Okay, so what happens when a person has decided that they're going to make a change? When it comes to the example like smoking, many people start with reducing the amount of cigarettes they smoke. Now, this is normal. Small changes are part of the 3rd stage of change, preparation. People in the preparation stage are fully ready to make a big change within the upcoming month. They understand the benefits of the change and they want to move forward. But rather than diving in headfirst, they usually just test the waters of change to see what it's like. Now, this is an exciting opportunity to prepare yourself or someone else to make the leap. Enjoy this time in this preparation stage. The more prep work that you do, the easier it will be to transition into action and maintenance phases. So you can set yourself up for success by doing research on upcoming obstacles that you might face and how other people have moved past them. You can also create something called SMART goals for yourself. And something else that is helpful is looking up alternative plans of action in case your actions do not work out.
Okay, does anyone know what SMART goals are? What the S, M, A, R, and T stand for?
Yeah, I'm pretty sure we all have to use them for our therapeutic goals.
What are they, Miles?
They're specific,
Yep,
they're measurable, they're attainable. They are, I think there's some people say R is realistic. I forget what the other potential R could be, but I know T, relevant, and then T is time specific.
perfect. So just for those of you who don't, thank you so much for that, Miles.
Now, the more knowledge you have moving forward, the easier it will be to evaluate failures and move forward after successes. But after the preparation stage, we have step 4, which is action. Reducing the amount of cigarettes you smoke is a small step. Putting down the pack for good is a giant leap. And at this point, a person has entered the action stage. It's important to remember that the first 3 steps provide a foundation for the action stage. Quitting cold turkey just moments after watching a documentary about the dangers of smoking works for a few people, but it's not guaranteed that everyone will successfully quit smoking that way. Pre-contemplation, contemplation, and preparation are extremely important steps. After all, you have to want and know that it's time to change. If you think about it, this is why New Year's resolutions don't always work out. We make these resolutions in December and give ourselves less than a month, sometimes even less than a week to prepare. Without a plan of action or a support group, action only leads to insurmountable obstacles. Preparation helps to prepare for those obstacles and have a plan, not if, when you encounter them. But the preparation and the research doesn't just stop when the action phase begins. If you're ready to take action, know that your journey is far from over. You should continue to seek out support groups and other outside resources. And whenever you do encounter success, be sure to reward yourself. Now, usually the action stage lasts for around 3 to 6 months, in which the person will likely face multiple obstacles and sometimes dance with relapsing or going back into old behaviors and habits. Next, we have step 5, which is called maintenance. Once a person has kept up with their change, whatever that is, for at least 6 months, they enter the maintenance stage of change. Now, relapse is still possible, but a person in the maintenance stage feels more confident in their ability to stick to their change in behavior. For any habit, temptation will continue to pop up during this phase. And if you want to avoid a relapse, it's important to know that these temptations exist and to have a plan to avoid them. It's also important to know that relapses may happen. The more honest you stay with yourself about this possibility, the easier it will actually be to recover whenever a relapse happens. Lastly, we have step 6, which is relapse. Because relapses happen, they just do. When it comes to substance abuse, the relapse rate falls between 40 and 60%. It can be hard, even after 6 months or 5 years, to avoid temptation, because falling back on old behaviors is normal. What you do after a relapse, though, will determine whether or not you stay in the model and continue to change. For example, shaming yourself for relapse is not always healthy. Taking the time to honestly look at what triggered the relapse, though, that is very healthy. Look closely at what barriers you face and when those barriers become too much. Now, this information can help you moving forward. It's always important to keep your vision in mind. Pull what you learned from the first 3 stages of the trans-theoretical model, and then you can start over again. I know this video may have been a little much, but I know there's a lot of people wanting to learn about the trans-theoretical model, and I hope this video helps shed some light on it. I hope you've enjoyed it, and I definitely hope you've learned something. If you have any questions about this.
All right. So one note I do want to make about the term relapse. So I worked in the addiction field for several years. It was I mean, I don't necessarily need to substantiate myself in this or anything, but one of the terms that we used was lapse. So differentiating between a lapse and a relapse. So sometimes, so for some, it may be semantics. For us, we had different definitions of that. So a relapse tends to be a like complete return to previous behaviors, previous habits. A lapse is a temporary return to behaviors, habits. So particularly in with addiction, a relapse can be really filled, or the idea of a relapse can really be filled with shame of I am a failure. I knew I couldn't do this. You know, everyone who told me they didn't believe in me was right, that kind of stuff. So if it feels right for you, I like to differentiate between a lapse and a relapse, of a lapse being sometimes very necessary to learn, just like it talked about in the relapse stage of the trans-theoretical model, of that being an opportunity to learn a little bit more about your triggers. Sometimes people will test themselves. Like like we've talked about in some of the trauma work, of I want to go back to wherever I was experienced my trauma to change the narrative, or to feel like I had some sort of control and power over this. When you are feeling controlled or under the power of someone else or something else, we tend to want to have control and power. It's human nature to want that. So I just want to make a note of that, that if that feels right to you, sometimes it's important and can be beneficial for clients to differentiate between those two. Comments, questions on the trans-theoretical model? Okay, so I also wanted to just highlight a couple of resources that I added into Canvas. So I have a readiness to change. It's really simple. A readiness to change assessment, where you can present this to clients, where they just mark from 0 to 10 where they're at on the ruler. So anything under 5 denotes potentially some contemplation or pre-contemplation. But I also included the like how to score it and what it means. So how do you administer it? How do you score it? And then some follow-up questions. The only thing that I will encourage you to do is potentially, if you choose to use these questions, is to reword any of the whys with a not why question. So like, why did you put your mark there and not closer to the left? Can you tell me a little bit more about your decision to mark where you did? So I just really like to encourage students to take out to reword any questions that start with a why, because it can feel attacking, and there's always a different way to word a question. So I also included some characteristics and strategies when you do have a client, when you have assessed for their stage of change, of some ideas of what to do with that and what you might see in that. Okay, so one thing that I want you to be aware of is if you ever experience a client either in session or they have expressed out of session this happening of this like state of immobility. So this doesn't necessarily mean that they're catatonic, but it can mean that they feel very stuck, that you should treat this as an indication of them being overwhelmed. So this, and then assessing for what might be influencing their overwhelm. It might be multiple life crises or to triggers that are happening either in therapy or outside of therapy. You should assess for both. The pace and perceived pressure of treatment, insufficient stabilization within treatment, and insufficient emotional regulation. So maybe you moved quickly through that. It could also be due to ongoing abuse, ongoing trauma, and potentially that they have recently experienced victimization. So just if you notice this, if this is being described to you, please assess for these possibilities. So there's also some like motivational enhancement that can be used within when you are working with a client, understanding, where they're at in their treatment, in their progress. So motivational enhancements informed by motivational interviewing. That's what MI is. It's an approach. So you want to not only like talk about why change could be beneficial, you also want to very much understand the cost of change. So anytime a client experiences change, anytime we as humans experience change, there's inherent loss in it. Loss of maybe an identity, a piece of your identity, loss of predictability, loss of comfort. So change isn't just inherently good. I always want you to be aware of the cost of change. So you want to understand both the pros and cons. So you would ask questions or understand what they view as important, what the client views as important to change in their lives and their own personal reasonings for wanting to change. So this may be based on discrepancies so one approach that we use or one technique that we use is like the real kind of versus ideal person. So like what if I were to achieve everything I wanted, like what would it look like? How would I feel? How would I move? How would I posture myself? All of these things. So there may be a discrepancy between where they're at right now and where they would like to be. And then you also want to understand what they don't want to change or what they view as lower priorities to change. So again, you're making sure that everything that you're providing is relevant and congruent with the client. So you also want to know areas where they do want to change, but also identifying any cost to that in actually changing or attempting to change. So going through this process allows the client to feel more informed about their decision and also validated in like, oh, change is scary. Like I'm not just being forced to change and, force this narrative that change is always just positive. It's only beneficial. There's nothing to be worried about or scared about. It really validates the complexities around change and Also what they're willing and able to work on in therapy and what they're not. So then you stay in step with them, which increases the therapeutic alliance, which is kind of the basis of any sort of movement that you make in therapy. So also in motivational interviewing is like kind of their tagline is rolling with the resistance. So you want to, this can be in a way prevented, not with every client, not in every instance, but what you want to do is, sorry, these should be, man, all kinds of stuff going on here. It doesn't really matter. I'll update it. Okay, so what you can do is be very cautious when making suggestions. So again, recognizing that if you give a quick fix, if you give this suggestion that you think is really beneficial to the client, that they may not receive it that way. So if you do give any sort of suggestion, you better have done some work beforehand with the client. So you want to be cautious about making suggestions until the client feels these several things that are noted, is that you really do have their best interest at heart. So we'll talk a little bit about some of the threats to the therapeutic alliance, that you are able to anticipate the areas that might be particularly sensitive, any sort of post-traumatic reactivity and hypervigilance. So you know them well enough to be able to integrate that and acknowledge that and prepare for that with the client. So you're having like these explicit dialogues about this, that you know them well enough to be able to gauge their emotional capacity and tolerance for whatever you may suggest. And then you're phrasing your suggestions as this natural, logical extension of what they're already doing. So that is sending the message of like this belief in them, this congruence with them, and this connection and attunement to them, so that they're not having to make these like radical changes where you don't like, that's not feasible. Like it's something I'm already doing. It's an extension of something I'm already doing that feels feasible. If it's something completely different from that, they may feel like you're not understanding their context, you're not understanding their reality, you haven't been listening to them. So these are some things to keep in mind. And then of course, the concept of rolling with resistance is recognizing that resistance is going to happen. It's resistance, so it's like, it's a pushback, it's a questioning. So resistance is, I think it's not always fair to, talk about the client's capacity or their willingness or anything like that, because it may not, it's never just like one simple thing. But this term rolling with resistance is in motivational interviewing, so I'm saying it. But what you can do with that is you are validating their concerns. You are allowing space for them to talk about their concerns, because what you're doing is communicating to them that I'm not against you. We're on the same team. So whatever concerns you have, let's talk about them. Because if you say, oh yeah, I hear you in that concern. Oh, it's don't worry about it. It's really not like that. That all you're sending to the client is I'm not attuned to you, and I'm being dismissive of your concerns. So I'm going to talk specifically about what the threatening aspects of like inherently threatening aspects of the therapeutic relationship are. So just recognizing that you're balancing this paradox of fear of people who are in authority figures, authority positions, this fear of like interpersonal relationships in general, but this reliance on you to help with progress. So just remember that there's this constant tension that can be in the therapeutic relationship of like, I'm afraid of you, but I also am reliant on you in some way. So I'm going to do what I can to kind of have some control in that. So here's some threats to be aware of this. So again, this paradox of having a history of being deceived, or this fear of being deceived or betrayed, but at the same time, really longing for a sense of trust and the ability to trust. So again, just being sensitive to that and not slapping a label of like borderline personality disorder on that, not saying, oh, this client's just so frustrating. It's by being trauma informed and by acknowledging that reality, it gives you some more patience in that, and it gives you some more empathy in that, and allows for you to be more sensitive to the client and their context. So another threat to the alliance is this fear of abandonment. So this can very much happen in the therapeutic relationship where, hey, guess what? We're humans too, and we take time off. And we may need to take extended time off for whatever reason, extenuating circumstances, life adjustments, that we also aren't a 24/7 repository for your stuff, that we're humans that need a life professional balance, a work-life balance. So being very overt about, so if you have not office hours, you have hours of operation, like if you only answer your phone and only, connect with clients between the hours of 9 and 5, Monday through Friday, let your clients know that. So they're not feeling like, so if you have it, if the default is personalization, right? If my therapist isn't answering my phone calls, if they're not calling me back within 10 minutes of a phone call, they hate me. They're firing me, so just knowing that that can be a default thought. So being very overt about when you're available, limitations to that, any planned time off, so you can, plan around that. So then there's also the fear that as a therapist in this authority or expertise position, that you may use that position to intimidate, coerce, belittle, or otherwise try to violate the client. And so you want to balance this support and attunement with these boundaries around the client's needs. So again, you're not a regular person in the client's life. And the boundaries of the relationship are also determined by the client's needs. So again, if they need you a little bit more and you're willing to do that, I would argue that it's probably ethically appropriate. If you're taking clients who have experienced trauma, I think you inherently have to be a little bit more flexible with your professional boundaries, meaning time and availability and stuff like that. That if you're going into this work, there's just going to be a little bit, maybe extra more that you have to provide to your clients. So for what it's worth, just keeping that in mind. And also if you have clients who are like, stay away from me, that you don't try to kind of force yourself on your clients and trust me, talk to me, I'm safe. Let that process happen. There also may be clients that are resigned to or ambivalently comfortable with being sick. So this may be part of their identity. They don't know how to not be sick. They don't know how to not be in the role of a sick person. They may also be in a system where their role of the sick family member or the sick system member really benefits the system. It helps maintain homeostasis. There's stake in them being sick. There's stake in them being harmed, whatever label has been on them, that they've been traumatized. That is kind of their lane, and they don't really know how to have an identity outside of that. They also may feel like if I get better, then I'm going to lose my relationship with my therapist. So I'm going to continuously be in crisis. I can only maintain a relationship with my therapist if, and then they do the if. So having that explicit conversation with them, recognizing the parameters of therapy, but also really speaking to that of, there is some limitation to what we can do in here. And perhaps offering this check-in of once we have our termination session, it doesn't mean I've slammed the door shut of the relationship between you and me. If you want to have a monthly kind of, 30-minute check-in, and that's something you're able to do within the organization that you're working, offer that, because it may be something that this change is very scary to the client. I've been in therapy, I feel safe here, I've made progress, and the thought of not having this space is very scary. Speak to it. And then of course, being aware of the adaptations the client has made to survive these traumatic experiences and cope with any psychological symptoms that come with staying in survival mode. So again, just recognizing that what they know needs to be needs to be adapted in therapy. So moving from survival mode to learning mode. But again, just not seeing that as this frustrating piece, it may be frustrating. It's okay to be frustrated, but not letting that overcome you or be like the pervasive, like emotional experience that you're having towards your client. So again, recognizing that all of these things are inherently threatening to the alliance. So to me, the best thing that you can do is speak to it very explicitly. So then I wanted to talk with you about the actual setting, the actual space where you are providing therapy. And right now, I know it's a little bit different because they're likely in their own space. You're likely providing maybe the majority, maybe not, but many of you may be providing the majority of your therapy like this. But the setting is really essential. So where the setting is not only the physical space, it's also the environment, like the emotional environment, how you attend to the client. So that's the setting as well, the emotional setting. So these 5 essential conditions of safety, trustworthiness, choice, collaboration, and empowerment. So if these are kind of like the default words that you think of when working with a client, I think you'll be in a really good place. And then do we have time to watch that? So this is really just a video about the actual physical space of an office. So some things that they talk about in this video is how to set up this space to be non-threatening. So one of the things that we always learn, I would guess that they teach you at Alliant, is we should be closest to the door. As a therapist, we should be closest to the door in case a client gets violent, that we're not trapped, because therapists have been murdered in therapy by a violent client who may have dissociated, who may, whatever it is. So we're always taught safety first for us. At the same time, with a client who has experienced trauma, you being an obstacle to leaving the space may be very, very dysregulating for the client, very threatening for the client. So I'm not saying don't sit closest and have like a clear line to the door, because the client shouldn't be an obstacle for you, because you may have some trauma history, or like your life shouldn't be at stake in your work. So basically, one of the things that it's Peter Levine again who's talking about this, where he puts his chairs at like a 45-degree angle. So because sometimes it's very intense to be like, look at me, or we're nose to nose in this, we're face to face in this, that it might be less threatening to be at a 45-degree angle, so you can kind of like gaze off if you need to, but that there's a clear route to the door for the client that you're not in the way of. There's also a clear route to the door that the client's not in the way of for you, so that both people have an opportunity, so that you're not potentially exacerbating this experience of being stuck. I'm stuck in a situation that I can't get out of. So just being really aware of that. So if you want to, feel free to watch that video. I think it's like 3 or 4 minutes long, but I of course want to privilege some of the mindfulness techniques that we've established wanting in this class. So being just aware of your office. What kind of vibe do you have in your office? All right. So then another thing to really be aware of and to speak to, again, speak explicitly to, is your personal introduction as well as your therapeutic introduction. So as you, even, if you're the person that does intakes or something, making sure that, remembering that the therapeutic relationship starts, even if it's not directly with you, the therapist, if it's with the agency or something, the therapeutic relationship starts with that initial call. So if if you are in a space of hiring a administrative assistant or something like that, make sure that they are very calm and attentive. So being calm, attentive, and emotionally imbalanced right from the get-go. Like that's your personal introduction of, this is the emotional environment that you can expect from me. So being very overt about, what is my approach to psychotherapy? Working with me, what can you expect? It's no different than if you were to, go to a medical doctor and they were to outline the treatment for like a post-surgery knee, like meniscus recovery or something like that, that you have an idea of what is to be expected. We should be no different in that. Of course, we have variability because we kind of have to roll with whatever's going on, but you can give them at least a roadmap. And I think that's really important. So this speaks to potentially previous relationships, not only with like people in their personal life, but also with potential professionals that have been either confusing or damaging, exploitative, that if you can say up front, here's what to expect, I'm going to be very transparent with you, that can go so far. So I plucked this quote out. I don't love all of it. So one thing I will note, just stylistically, personally for me, is anytime you can say that you want to say but, I encourage you to say and, because but sends the message of, what's the word I'm looking for? That it's mutually exclusive, that this thing is in opposition to or cannot exist without this other thing. So just stylistically for me, I encourage you to say and. So it's like, I love you, but I love you as well as I have this concern. So, but this is like the general message of, you know, you are not broken. You also are suffering, you're struggling with something. The things that and the symptoms that I see make a ton of sense in context. So we're going to adapt some of the ways that you've coped with your symptoms that have make sense to have been in this survival mode, this protective mode. So also taking the stance that therapy really should be collaborative and you are serving as a guide along the way. Remember, you have expertise and something to contribute. At the same time, the client is the expert on their life. They're the expert in some ways on their experience, because they may not be fully aware of their full experience, but just really defaulting to a collaborative stance. Okay, so then last but not least, in terms of the setting up for the practical arrangements for therapy, so being overt and having a conversation around service fees and conditions. So for as a society, you know, that we're always like kind of about talking about money, but there shouldn't be a mystery to fees. And also, if you are hesitant to talk about that, one, I encourage you to explore that and understand why you may have some difficulties with that. But remember that being explicit and overt about these things can really be reparative if the client has been exploited, betrayed, or deceived in the past. So saying, again, there's no mystery to this. I'm going to be very transparent about all of the pieces of this process. So the last chapter, I think this actually is from Herman. So the note, and I really, this visual and this metaphor is, I think, really beautiful and applicable to what we do, is that the progression of the stages through treatment are nearly never linear. Stages are kind of inherently flawed in their conceptualization because no one goes that cleanly through anything. So it can better be described as this spiral in which earlier issues are continually revisited on a higher level of integration. So as you build the skills, as you're learning more about yourself, you can revisit some of these things and topics. And I would really encourage you to note and say to your client, wow, like the last time we talked about this, this was my experience of this, and this is what I saw in you. This is progress. This is different. Congratulations. That's wonderful. So really highlighting and punctuating any progress when you see it. So again, a lot of this is reiterating what we've already discussed because there was quite a bit of overlap in the readings this week. So this explicit questioning that is often required to determine is like the present danger and ongoing experience of the client is overlooked. So please make this a routine part of your assessment. Also, just again, in the spirit of transparency, in the spirit of this collaborative stance with your client, if you think that the client is suffering from something like some sort of traumatic syndrome, let them know so the client can be fully informed about that. So they have some agency, so they have some language around that. So again, yeah, in the spirit of transparency and being explicit. Also recognizing that sometimes clients are going to hold back on the acknowledgement or sharing that they feel some sort of kind of like psychological scar or psychological harm from their experience, because they feel like that's like the perpetrator won. But in the psychological, so again, it's this disconnect that we kind of have between our minds and our bodies of, well, I can't really control how my body responds. Like if you hit me and I bruise, like I didn't really have control over that. But if you traumatized me and I have these residual effects of that, I should be able to control that. So I'm not going to acknowledge it. I'm not going to talk about it, because then you win. So we just like, I think we feel like we have a lot more control over these very natural neurological responses in our brain in a way that we don't feel like we have control over our physical bodies. If anyone is not following me in that, please let me know. So some clients may feel like if I do acknowledge this, then I've lost in some way. So what you can do is help reframe them asking for help as this courageous act. So acknowledging the reality of one's condition and taking steps to change it can hopefully become this belief, this perspective of strength rather than weakness, and this stance of initiative as opposed to some passivity. So, you know, the possibility of reframing their seeking help. So as we've seen in the videos and as we've talked about in class, survivors can feel wholly unsafe in their bodies. So their emotions, their physical container, their thinking, everything feels out of control. They also may feel unsafe in relation to other people. So there's nothing really safe in their world. So establishing safety starts internally, and then you want to move outward to their environment. Of course, if there's a crisis, you want to attend, like an environmental crisis or something, you want to attend to that. But these are things like checking in on basic health needs, like sleep, how's their sleep, how's their eating, are they able to move? So again, exercise, of course, is helpful. There's research upon research of the utility and benefits of exercise. It may not necessarily be something the client has a ton of access to. Because I'm even thinking about like, oh, well, if they don't have monetary resources, then they can like exercise outside. But if they're in an environment, if they're in a community that's inherently unsafe, where do they go? And do they have transportation to go to another place? So you really have to take into consideration their context. Then of course you want to make sure that their housing and their living situation is stable, it's safe, that they have some financial security. Do they have any mobility? Are they able to move from place to place if need be? They have a plan of self-protection if their living situation is not safe. And recognizing too that you can't establish a safe environment alone, that they will need to engage some social support for that. All right, we're getting there. Last slide. So establishing a safe environment. So this is not only in the therapy room, but outside. That the initial evaluation is a careful review of all of the important relationships in their lives, recognizing that not all the important relationships are safe. They can be a potential source of danger. So, don't assume that their parents or their partner is like a completely protective force in their life. Also, I really want to highlight this because I think sometimes, again, when intentions are good, one of the things we've been reading about is like this restitution and this, community acknowledgement of the atrocities that have been that they've experienced at the hands of another human being, that like justice is served when that person pays and when people know what they did, and that can happen within our criminal justice system. And as we know, our criminal justice system is not kind to survivors. So in the matter of criminal reporting, you may say, we've got to do this. Like, this is something that will be helpful in your recovery and your healing. If the client doesn't want to do that, don't do that. That is taking, if you do that without the client's consent, you are absolutely rupturing the alliance. You are dismantling the trust. You are destroying some of the foundational aspects of the work that we do. So really all of this is like the default to the decision, like the default decision-making process, or the decision-making process needs to default to the client. So like in a matter of the self-care and the question of involving family members in treatment, client should absolutely sign off on that. In terms of safety in a relationship that's ongoing where they've experienced intimate partner violence or domestic violence, you can't rely on the perpetrator to provide safety. At the same time, you can't expect the client to just like move away from or get away from that person. What you want to do is create a safety plan of self-protection that the client can implement. So until the client has developed a detailed and realistic contingency plan that has demonstrated their ability to carry it out, they remain in danger. And you can't force them at any point to do something that they're not willing to do in that. So again, it's always defaulting the decision-making process to the client. So that's that. Questions, comments, concerns before we go into our guided breathing. So this is very different. I want to give all of you very different mindfulness techniques, because so for me personally, I really like guided imagery. I really like progressive relaxation because I like hearing a voice and I like not really having to think. This one has very little cues, verbal cues. But some people really like that. They want time to just be internal, to like follow their own thoughts. So I'm going to ask you to get in a comfortable position again. And remember that I'll let you know when the video's over. There may be times where you're like, wait, did I lose audio? Am I still in class? Did she end class? No, it's just that there's very little verbal guidance from the video. All right, so go ahead and get nice and comfortable. Feel free to turn off your video, and we'll take the last 10 minutes of class to do some breathing meditation. And here, there may be a, let me just check to see if there's gonna be a, yep, this.
Hey guys, welcome to Forward. We're a new type of doctor's office that's providing preventive.
In this meditation, we're going to be doing a guided breathing practice to help you slow down your thoughts, calm your mind, and soothe your nervous system. You can do this lying down or sitting with a nice straight spine. Get nice and comfy, and we'll get started whenever you're ready. Rest your hands wherever they feel most natural. When you're ready, close your eyes. Or if you'd like to leave your eyes open, you can lower your eyelids and soften your focus. Before we start changing the breath in any way, just notice how you're breathing. Bring all of your awareness to your breath. Notice how far into your body the breath comes. Is the breath shallow or deep? Notice how your body feels. Start to slow down your breathing, breathing in through your nose and breathe out through your mouth, keeping your mouth almost closed. so that the air makes a shushing sound as you exhale. With each inhale, bring all of your awareness to the sound the air makes as it enters slowly through your nose. Feel the breath filling your lungs. On each exhale, listen to the sound of each slow exhale passing between your lips. Keep your mouth almost closed. Feel the gentle sounds of your breath, slowing your thoughts, calming and soothing your body. Imagine breathing right into the base of your stomach. Let your belly soften, relax, and swell with the in-breath. Notice the way your body responds to these slow, soft breaths. If your mind wanders or you start thinking about something, as soon as you notice, just bring your mind gently back to your breath. Just allow your mind to rest. Just breathe. Now let go of making a sound with the exhale and just breathe out through your nose or your mouth, whichever feels more natural. Focus on the soothing sensations of the breath. Feel a calm expansion as warm air fills your lungs. Feel your jaw and all the muscles in your face relax as you exhale. On your next inhale, breathe into the back of your lungs. Feel your back release and relax as you slowly exhale. Imagine you can breathe into your pelvis. Feel your legs and feet relax as you breathe out. Breathe into the sides of your lungs on your next inhale and feel any weight on your shoulders lift with the out breath. Imagine you can breathe through the top of your head into your entire body and feel your whole body relax and release with the out breath. Now let go of deepening or influencing the breath. And let each breath naturally rise and fall. The breaths might be deep or shallow, fast or slow. You can completely let go. Allow your body to take over. Follow the rise and fall of the breath, noticing the way it feels as the air enters and leaves your body. The breath might pause sometimes, or it might be completely continuous. Just allow each breath to arrive when it chooses and leave your body when it's ready. Let go of control completely. Notice a stillness in your body as you breathe. You're completely at peace and at home in this calm stillness. It's almost time to return. Take a couple of deep breaths. Imagine you're breathing this stillness into every cell in your body. Start to wiggle your fingers and toes. Feel the weight of your body on the surface beneath you. Notice how you feel. Notice how your body feels. When you're ready, you can open your eyes. And before getting back to your day, give yourself a big thank you for taking this time. Have a gentle stretch. This meditation is here for you anytime you need it. And anytime you're feeling anxious or need to calm your thoughts, you can use the shushing breath and the deep breathing that we did together to help you slow down your mind and soothe your nervous system. Let me know how you got on, and if you have any
All right, everyone, no need to turn on your cameras or anything like that. Just want to thank you for sticking around with me a couple minutes after I came into my room because there was some noise going on and there's not a lot of audio with this. So I hope that you're feeling nice and relaxed, but still able to continue with your day. I will see all of you in 2 weeks. No class next week. I'll be available during this time though, if you have questions or anything like that. But please take some time to enjoy next week off. And I will see you again on the 19th? No, the 19th. All right, y'all. Have a great rest of your day. Thank you.
Thank you, Dr. Lappin.